So what I'm going to do is I'm going to read out the question and then pick on someone who I think might be best placed to answer it. Okay. So the first question, I think, is actually for Sheila. And it's from Nick Smith. And the general question that Nick asks is, he entitles it lack of communication, but I think it's a bit more subtle and nuanced than that, really. So Nick notes that St. Mark's solution is very important to patients with a stoma. He was expected to require dialysis last September until a renal dietitian suggested that perhaps he should start trying St. Mark's solution. He's been seeing renal consultants and nurses every quarter, but they've never heard of it. They've never heard of St. Mark's solution. And why is there such poor communication, I guess, within the profession? And he's now told he probably won't need dialysis for another 5 years. So, I guess the question is, why doesn't the profession as a whole recognise the importance of these kind of management approaches to a high output stoma?
Coming through. Hello, you can hear me now.
Yep.
Thank you very much. That's a really important question because I've worked across both fields. I've worked across surgery and colorectal nursing, and I'm working in medicine and renal medicine. And actually, sometimes the surgeons, the medics, they don't really communicate very well. And often patients that come in with high output stomas sometimes come in under the medical teams rather than surgical teams, and they're not particularly managed as well as they should be. So medics don't tend to know much about St. Mark's solution, and it's usually dietitians that tend to know about it, but unless they refer to a dietitian, that they don't get heard. I'm trying where I work to try and bridge that gap because I've had a foot in both camps now. But I completely agree with you. St. Mark's solution is absolutely vital for patients with high output stomas, but the in-care hospital care isn't always very good. And I've been educating my renal physicians, my renal colleagues, all about St. Mark's solutions. So St. Mark's have produced some fantastic guidelines as well on high output stoma management, which is also what is adopted by the Association of Stoma Care Nursing. It's based on that. So I've been disseminating that to all my renal physicians so that they can actually improve their knowledge. But it is definitely an area of deficit. So I think we just need to work more closely together as medics and as surgeons, and looking at high output stoma through a kind of renal lens so that we make sure that, or through a surgical lens really, so that we make sure that if you are going in from a renal perspective, looking after somebody's high output stoma, that actually you're looking at the surgical side of it as well and making sure these sorts are replaced. So yeah, good question, thank you.
It is a good question. I would make an observation that the nature of medicine that I've seen over the 30 years or so of my career is that health professionals now know more and more about less and less. So what we tend to do is we work increasingly in silos and have, deep molecular understanding about the molecular pathogenesis of disease and a whole array of treatments for them. But we actually know less and less about what our colleagues do in some of their practice. And that's, I guess, inevitable as people get more and more specialised. And it's interesting, when I was a junior doctor in Salford, there were any number of people who would be regarded as general physicians who we could get to come and see a patient who was unwell, particularly if we didn't know what was wrong with them. You can't do that now. You have to actually refer someone to a specialist gastroenterologist, renal physician, cardiologist. And if the problem isn't within their field of interest, they're often equally dumbfounded and not really sure how to take things forward. And I think it's just a reflection of super specialisation, really. Any other comments about St. Mark's solution generally? Anyone want to say anything about it?
So I was just going to say, Gordon, I think you're absolutely right, but I think the silos are not just psychological, they're often sometimes physical or architectural. When you have one specialty at one end of a hospital and a half a mile away on the other end of the site is where the other specialty is, or indeed a different hospital, it becomes really difficult to have that true multidisciplinary team working because you are not physically co-located. There are systemic barriers which are difficult to overcome sometimes.
Yeah, agreed. Okay.
Gordon, can I say something?
Yes, please, Carol.
Could I say that there's also a place here for the patient to become the expert? and know for themselves what they need, and that's our role to educate you. Because you are the experts.
Agreed.
And if you know that you need St Mark's solution, then you make a point of telling everybody when you get there.
Agreed. Okay, the next question's from Patrick Mullen, and it's for David Jane. So Patrick wants to know, David, what role do you see for AI in tech innovation and treatment specifically for inflammatory bowel disease?
Oh, wow, that's massive. I think you have to understand what is AI, don't you? It's a bit of a mystery term, but it covers all sorts of different disciplines within it, whether it's machine learning, natural language processing, etc., etc. There's an inevitability that AI in all sorts of forms will come more and more to the fore. I think where specifically inflammatory bowel disease, inevitably I would think around the diagnostics of it, because AI is good, machine learning is good if you have big data sets and computational things that the human brain can't do easily. And as we understand more and more about particularly the genetics of diseases, I think that's where the power of computing will probably come in. But it's a big question, and I'm sure it will have multiple different applications.
Any other comments? I think we're still finding our way very much with AI. I made the mistake of using Microsoft GPT. I don't know if anyone's actually used that tool. It's remarkable because you do feel you're talking to a human when you ask it a question. You get an answer back, which is like a type response from a human in lots of different ways, one of which was it was absolute crap. So I asked it a specific question, actually. I can't remember what the question was. I asked it a question, what percentage of appendectomy has to be converted to open surgery these days? And I got, really detailed answer. And you can say to it, could you tell me more? And you get more. And you say, can you provide a reference to that? And you got a reference. The reference doesn't exist. And then when you challenge the machine, it said, oh, I'm sorry, I made that up. And really, that's genuinely what it said. Oh, I'm sorry, I was wrong. I must have made that up. So, I think it's very exciting, but, in its infancy. Okay, next question. I think probably for Neil, actually, given the nature of your presentation. It's from Maureen Naylor. And Maureen wants to know, how do you encourage patients to become PPI members?
That's a really good question. So there are ways that you can do it just by going to NIHR website. There's a thing that you can click and it says get involved, and it will take you through the portal for things to do. Most local hospitals as well will have dedicated PPI committees for one, feedback on services, but also dedicated research ones too. So my own hospital has a dedicated PPI for clinical research, but there are other institutes as well. So, for example, we've got a local NIHR clinical research facility, and that also has a dedicated PPI panel who tend to feed back on more complex problems, which are often things like genomics testing. And they often advertise in the local press or through posters in the hospital, and you'll often see them around, are you interested in research? Please send an email or click on the QR code or something like that. So there are often ways and means locally within your own communities, particularly if you're in a healthcare facility, to see that, but you can do it nationally as well. And often patient organisations will have panels that they will convene to engage with research communities. So Association of Colour Proctology has a dedicated public and patient liaison committee, and many other organisations which are surgery or medically society specific will have something similar. So look out for it. It's often available on social media, Twitter, internet, those types of things.
Thank you. Maureen, does that answer your question?
Yeah, the main problem was that it's getting to that stage in the first place. So it's actually encouraging. How do you encourage people, to say that, it's something that you can do. You don't have to be scared of doing it. So before you can click on a link to say, I want to be a PPI, it's before that I was thinking of, really.
Yeah, I agree it's a challenge because the people who go looking at things like the NHR website are often a certain demographic, and I think that's why you'll find, to try and widen participation, it's why you'll find people like Tom, myself, David here, for that very reason, to advertise the fact you all can, and we want to welcome you all there. There have been challenges, I think we have to be honest, in the past with public and patient involvement. There have been some difficulties because, let's be honest, it's very difficult to be what you can't see. And we've noted, particularly over time, that the people who get involved with PPI work, they are a particular demographic, and we don't reach all parts of our society in terms of all the measurable things in terms of diversity. So, there have been issues, and there's still work in progress to try and address all of those, particularly from a quality, diversity and inclusiveness perspective. So, I encourage everyone to come forward, get involved.
Okay, next question is anonymous, but I think it's directed to Sophie. Is there any benefit for ileostomates to take probiotics and vitamins, or is it less likely they will be absorbed, and so are we wasting our money?
Yeah, great question. And the truth is we don't know the answer to that for sure yet. So we certainly know for the vitamins, so I'll talk about that in a minute. But on the probiotics front, we just don't know at the moment. So the main targeted benefit of almost all commercial probiotics is to colonize your colon. And of course, you guys don't have a colon. So in that sense, we just don't know what the benefits might be. There are particular probiotics like VSL, who are here today, that do have some evidence for pouchitis and other conditions. But sort of to the best of our knowledge at the moment, there aren't any significant benefits to people who don't have a colon to taking a probiotic. Now, I do some work with probiotic companies and other people, and I also work with patients who have an ileostomy all the time. And sometimes they do say to me, I've started taking this probiotic and I do feel better. So I do believe in the not too distant future, we might understand more about the potential role for probiotics in patients who have an ileostomy or a pouch. But that doesn't mean that I want you all to go and spend £40, £50 a month on probiotics, because we just don't have the evidence to suggest that's the right thing for you to do right now. If you did want to try one, I would suggest that you try one of the sort of, some good brands are BioCult, Optibac, and Alflorex. Those are good, cheap brands that you can buy, but I would recommend that you empty the capsule, because the capsules are designed not to release the probiotics until they get to your colon. And of course, you guys haven't got a colon, so that's not going to be very helpful. So if you do want to try one, don't spend lots of money and empty the capsule before you take it and see what happens. There's no harm in you trying. On a vitamins front, if you're someone who lives with an ileostomy or you have a pouch, what you might find is some of the bigger, chunkier vitamins might come out into your bag, or you might lose them in the toilet, because they're just quite difficult for your body to break down, because things are moving through a little bit more quickly than we would like them to. So in that case, I usually recommend an effervescent multivitamin, and the brand that you can get on prescription is called Forceval. So you can empty that and put it into a drink, and you can drink that, or it comes in a soft gel capsule, so inside the vitamins are liquid, and it's much easier for your body to access those. Some people also find that mouth spray vitamin D is better for them than tablets and things like that. So there are other forms of vitamins that might be better for you if you live with an ileostomy or a pouch, but certainly vitamin tablets can be really beneficial and really important if you do have, when you don't have a colon.
Okay. Next question, and I'm not sure who this is for, but I'm going to give it to David. The small intestine is the same small intestine in a patient pre- and post-operatively. No blockages before surgery, why afterwards? So I think that's a very low-hanging fruit for a colorectal surgeon, David.
Yeah, if I get it wrong, you can... Yeah. So I think the problem you're referring to is called adhesions. So whenever you handle the bowel, you will traumatize it. And just as you might traumatize the skin, it heals by fibrosis. You get scarring. And so adhesions are the end consequence of the bowel sticking together because it's been made irritable and has been traumatized. So almost everybody who has abdominal surgery will form adhesions, but some people will make them a much denser adhesions than others. There are certain conditions, particularly if you get an infection at the same time, that will make the adhesions more dense, and therefore the likelihood of blockages becomes greater. And going back to the keyhole surgery bit, so one of the advantages of keyhole surgery is that the incidence of adhesions is much less. So if we can stop the adhesions forming, you should have less blockages.
Neil, do you want to add anything? I think it's an excellent answer.
Yeah, and of course the other common reason for getting bowel blockages is hernias. And what we know is that after colorectal surgery, hernias are really common, whether you've got a stoma or not. Just an incisional hernia may affect up to 40% of patients a couple of years down the line. Similar rate that we see for parastomal hernias in terms of the frequency, and those hernias can be problematic. So there's lots of research ongoing at the moment to try and look at how we can prevent those hernias from occurring, but it's challenging and it comes with its own risk, whatever you do. So,
and also dietary indiscretion. You have to be careful. I had a patient who celebrated his Christmas in hospital with his new ileostomy by having a pound of peanuts. That did not work out terribly well, and he was going back to theatre, unfortunately, on Boxing Day, simply because of the obstruction associated with it. And it was literally a pound of dry roasted peanuts. But, you know, there we go.
Let me just say that a pound of dry roasted peanuts would put most people in hospital,
yeah, probably.
let alone if you've had bowel surgery.
Possibly with hypertension due to the salt content, actually. Okay. All right, next question. There are, in fact, two questions from Sean. Again, I suspect this one's probably for Neil. Are there any developments in new developments in techniques or devices to prevent hernias and their associated problems?
Well, there are, I suppose, two things. The first is mesh, and there's lots and lots and lots of different types of mesh that are available out there. There are new ones coming to the market, although that flow has slowed because of the changes in regulation that have occurred in Europe and the United Kingdom in terms of how their processes for CE marking or the UK equivalent are performed. Ones that are made out of mesh which is permanent, mesh which is dissolvable, mesh made from bits of animal, and they're all in the process of being investigated in one form or another, some of them more in prophylaxis than others. Different shapes, different locations. It's a watch this space. In terms of techniques, particularly for patients who've got stomas, there's been a resurgence of interest in terms of how the afferent stomal limb is brought to the surface of the abdominal wall, and there's been much interest again in a technique that was originally described by John Gallagher and routing the stoma extraperitoneally. Now, it comes about every 20 or 30 years or so, someone revives it, and it happens for a while where people are keen on it, and then it kind of disappears, and it's never immediately been clear to me as to why, but perhaps some issues relating to blockages as the afferent stomal limb goes around the cut edge of peritoneum and gets routed extraperitoneally because it can kink. So it's great that there's no mesh there, there's no problems with the device that can go wrong or get stuck to things, but you can end up with other problems because of how you've done it. So it remains under evaluation. So watch this space.
And I think it's fair to say that it's, to a certain extent, clearly an intractable problem. There's never going to be a complete solution which is going to prevent parastomal herniation in all patients.
Or indeed incisional hernias. Yeah. And surgeons for a long time have looked at, what if I stitch the wound closed this way? What if I stitch it that way? And the answer is still, we haven't found that magic silver bullet. It isn't out there.
And what I would say is to reassure you, we spend as a community of surgeons a huge amount of time. We invest a huge amount of energy, both clinically and academically, in trying to find ways to reduce hernia formation in wounds and around stomas. So it's not something we know it's important. We don't take it lightly. It's a difficult problem to solve. Okay, the last of these formal questions is Sean again. And again, I think this is a relatively straightforward question. Can one still have symptoms of ulcerative colitis if the colon is removed? For example, joint pain and fatigue. Would anyone like to pick that question up? If not, I'd be happy to. So I think the most important thing you need to bear in mind is that there are certain similarities between ulcerative colitis and diseases like rheumatoid arthritis. So we think about rheumatoid arthritis as a joint disease. It is not a joint disease. It is a systemic illness where the brunt of the disease is an attack on the joints. But rheumatoid arthritis can cause skin problems, lung problems, kidney problems, as well as joint problems. Ulcerative colitis is a systemic disease. It is a disease where the brunt of the attack is on the large bowel. But patients with ulcerative colitis and other forms of inflammatory bowel disease often have other manifestations of their problem. Again, they have skin problems, they have joint problems. There are complex explanations involving things like immune complexes circulating in the blood. But what is very, very clear is that you often see a patient, for example, who's had all of the large bowel removed and who has a pouch, and you heard this morning from Abby, where they have a flare-up of an illness very similar to their colitis. We call it pouchitis, but they have a fever, they have joint problems, they have eye problems with it. And that's a manifestation of the fact that the surgery is to remove the organ which is most obviously affected by the disease, but actually the reason we get better results when we treat patients with these problems in a multidisciplinary team setting is because quite often patients do better if they also have medical treatment as well. It's not just about taking the colon out. So yes, you can definitely have eye problems, joint problems, skin problems if you have ulcerative colitis, even if your colon has been removed. Please. There's a microphone.
Thank you. When we have stoma or a pouch, we like to think that that's the be-all and end of all of it, and we can actually get on with our lives. However, when obviously very often you do have to have further surgery, but if the consultant or the specialist wants to give a spinal block rather than a general anaesthetic, does that render the stoma or the pouch sort of immobile during the surgery and afterwards for a short while, almost as if your stoma or your pouch has actually gone to sleep as well?
Okay, anyone like to take that? So what effect would a spinal anaesthetic have on the function of your bowel, stroke stoma, stroke pouch?
I'm not sure I know the answer to
Really?
this one, but I mean, theoretically, a spinal anaesthetic is usually in your lower lumbar. Yeah, so from T10, so the tummy level down. So, and the big problems with spinal anaesthetics mainly because, I mean, it does affect your autonomic nervous system because one of the problems is you can drop your blood pressure. And that can be the issue with it. So theoretically, one would think that it could affect the motility of the bowel. However, I don't know any evidence really to support that, do you?
No, I was going to say, because you elegantly highlighted the issue surrounding the vagus nerve with the vagus nerve stimulator. So much of the motor activity which promotes gut activity will come from higher up. So for much of the peristaltic effect, that comes from above. The stuff lower down is mainly about defecatory function and anal sphincter, so that can sometimes get affected because you're blocking some of the motor nerves right down at the bottom of the spinal cord, which control the anal sphincter. But for most gut things, I think it's actually the way in which it gets handled intraoperatively that causes the problem. So don't forget, there are as many nerve cells in your gut as there are in your brain. So the motor component actually intrinsic to the gut is extraordinarily complex and remains relatively poorly understood. So merely handling the bowel is just enough to upset the apple cart in terms of its function. I suspect it's not the anaesthetic component, it's what we do to it as surgeons just by touching it.
So the short answer is a spinal anaesthetic shouldn't normally affect bowel function. Okay, last question.
Going back to the question before about the ulcerative colitis patient. Sorry, going back to the ulcerative colitis patient who's had the colon out and they're still having other issues like joint skin. So could you still say factually it's correct that they still have colitis?
No, because they haven't got a colon to have an itis in. So, and you might argue that that's our fault because we describe the disease as ulcerative colitis, whereas, as I've just said, it's rather more than that. I think it is important to recognise that when patients have actively inflamed bowel, that's when they tend to have bad joint symptoms, bad eye symptoms, horrible skin problems like pyoderma, so horrible deep ulcers that people get with inflammatory bowel disease. And it would be wrong to give you the impression that that all continues even if the colon has been removed. You can still get eye problems and joint problems and skin problems, but they're considerably less common and much less severe if the colon's been removed. Okay, last question.
On the subject of dialysis, I am on dialysis. I've been on for 12 months, and when I went on, I phoned Leanne to ask her if there's anybody who does anything about dialysis or could help me. And she put a feeler out and got no response at all. So I do feel that we are isolated because there's just nobody seems to want to know about us.
I'm sorry, I have to confess, I heard very little of the question. Could you repeat it?
Didn't you? Dialysis.
Dialysis?
Yeah, I'm on dialysis.
You're on dialysis?
Yeah, I've been on for 12 months. And I spoke to Leanne National, and she put a feeler out for somebody who could tell me anything about it or talk to me. And there's nobody at all. I got no help at all.
In relation to dialysis?
Pardon?
In specific relation to dialysis?
Sorry?
To help in specific relation to dialysis?
With dialysis. Actually, the only one that helped me was a friend of mine on dialysis and said, don't have more than 1.3 fluid taken off. But nobody medically could help me.
Just to add, sorry, also the clinicians didn't know. So they either knew about renal or they know about bowels.
Yes.
But there isn't that commonality of pulling the two together.
There isn't, I agree. So you're not going to find a group of people with an interest in the management of inflammatory bowel disease who can advise you as to how much fluid you should take or should be removed, because that's what dialysis is all about. The people who are going to be able to give you the best advice about that are the renal physicians who manage dialysis. What I would say is sometimes a good renal physician who is not sure whether their patient's bowel problem will complicate the delivery of dialysis will ask their colleagues, usually a gastroenterologist, to advise them.
And can I just add, because I know a diet for dialysis is different than a diet for somebody with an ileostomy, and that can be quite complicated sometimes, because we tend to, with dialysis patients, we tend to suggest a low sodium diet, a low potassium diet, and that may not always be in keeping with, and that makes it quite difficult when you've also got to then have a low fibre diet for somebody with an ileostomy. So that's where you need to get your dietitians involved, because they're the people that may be able to help you. There are renal dietitians, and there are also colorectal dietitians, and they'll be able to get you a bespoke plan as to how to manage your stoma. But in terms of fluid management, as Gordon said, it's going to be dictated by your renal physician. So they'll look at your dry weight, and then they'll work towards that.
Okay. I'd like to thank you all. I'd like you to thank the panel for the excellent lectures they've produced today, for sitting there and taking your questions without complaining. And I'd like you to thank them in the usual way. Thank you.